Okay, you
Perfect.
see my screen?
Yep, and I think we are all ready. So if you want to give just like a brief introduction, that would be great, and then go ahead and take it away. We're looking forward to your presentation, and thanks all for joining.
Okay, I can start. Okay, good morning, guys. My name is Jan. I am a PhD candidate, and today I will present my project of my thesis. Uh, it's about a hospital readmission. And the title is Development and Evaluation of Feasibility of an Intervention to Reduce Hospital Readmission in Adult Patients. And I am Brazilian physical therapist, and my master's degree in health science. It's the same program I make my candidate. I love this picture because it's the to remit my thesis and my project and me. I participate in a group in Brazil about regenerative technologies and gel processing health. And Gemini too. I live in the south of Brazil, in state of Paraná, and it's my university. Why I chose this theme for my thesis? Because I live in the countryside, this small city, and when I work in a hospital, I can see the same patient in the hospital. And in my mind, oh my God, I need to study more about this and can understand why the same patient return to hospital. This city is small and have a one hospital, and dependent the other big cities to big hospitals, for example, is and this so difficult to the same patient, the same healthcare, and this so important to me because I can help the city and the system of health. The city, I am very glad and to help. And in my thesis, I chose 30 days to return to hospital to with a hospital admission, and the simple definition is secondary hospital admissions when patients return to inpatient care shortly after a primary discharge to investigate or treat secondary causes involving the context, epidemiological, and with the sociodemographic changes and increasing diseases complexity, and to rising readmission numbers. The about the system it's very relevant because the readmission is a key result in public policy focus due to its severe implications for care quality and healthcare expenditure. About the demographic predictors, it's with the advanced age and male gender are consistently linked to higher risk of hospital admission, and the patient with older adult vulnerability, sorry, high prevalence of chronic conditions and frailty in elderly populations, it's very significantly to contribute to recurrent hospital stays. In the Astorga, it's a very big problem. Brazilian hate have a data from 2013 and National Health Survey estimates a hospital admission at 6% hospital admission rate in Brazil. About the geographic heterogeneity, admission rate across Brazil vary considerably according to region, hospital complexity, and patient clinical profile. and have so many socioeconomic barriers, low income and low education attainment, uh, hinder care continuity and post-charge sex. Uh, about the chronic disease drivers, it's a big problem too because have many people with this, and for example, the cardiovascular disease and respiratory conditions. It's major drivers of 30-day readmissions. Morbidity factor, patients present with multiple complex comorbidities demonstrate a high readmission rates too. Outpatient follow-up deficits, inadequate outpatient support immediately following discharge elevates readmission, and network fragmentation, lack of coordination between hospital services and primary care. In UBS in Brazil, it's a primary care, and you see this SAIGA, it's in Brazil, remains a critical flaw. Self-care knowledge gaps, insufficient patient education regarding medication, and post-charge self-management increases relapse risks. And in an introduction to readmission leads to functional decline and increase in morbidity and mortality and the lower quality of life, and the unplanned returns to intensive care needs represent critical clinical compensation and severe prognosis, financial and the research strain. Secondary administrations increase healthcare costs and the other problems too. It's why this theme? Um, Mitigating readmission prevents health status decline, complication risks, and the avoidable mortality. Reducing preventable readmissions preserves public health and funding and the hospital's bed capacity, and the curtailing patients' risk profile laws designing high intensity and the other problems too. And about the addressing system and we cover care gaps and for example medical errors, traditional failures, and the evidence based health policies provides empirical scientific data from to inform regional public health and promoting fosters and patient-centered care strategies linked tertiary hospitals with community and the healthcare networks. And about the regional of Paraná, it's an administrative role, is location in Maringá. It's responsible for coordinating, planning, and supporting public health services in Northwest Paraná. And to encompasses primary care clinicals and specialized outpatient services and the other hospital centers. About the epidemiological need made by a high burden of chronic no communicable disease and the other disease too. What my thesis objective is develop and evaluate the feasibility of an intervention to reduce hospital readmissions in adult patients. The other objectives I separate in three because in my thesis have three articles, and about the article one, analyze the effectiveness of literature documented interventions aiming of at preventing reducing adult hospital readmissions. The article two analyzed predictors of hospital readmission among adult patients in the third, sorry, fifth health region of Paraná using Unified Health System, the SUS in Brazil, secondary data. The Article 3 co-design a contextualized intervention to reduce hospital readmission and evaluate its implementation potential. Então, about the ethical considerations, the Article 1, 2 use exclusively secondary published public domain literature and the analysis secondary data. And the Article 3 was approved in the ethical committee. And the Article 1, I will make a systematic review protocol, and the purpose identify critical appraise and the synthesize scientific evidence on readmission factors and effective preventive interventions. It's conducted according to Prisma and registered on the Prospero. In the PICOS strategy, it's a population intervention comparative outcomes in studies type with the population adult patients with third-day hospital readmission, interventions designed to reduce hospital readmission, no readmitted patients, usual care or control groups, outcomes third-day readmissions, mortality, time to readmission, and healthcare costs, study type cohort, case control, cross-section, and clinical randomized trials. And about the electronic databases, I will use PubMed, Medline, Embase, Scopus, Web of Science, and Cochrane Library, and Lilacs. About the grey literature, Google Scholar, international repositories, clinical trial registers, and search strategy. I use the mesh, desk, M3 combined with the and or and any case search descriptors, hospital readmission, patient charge planning, transitional care management, and randomized controlled trial. And I will use dual independent review to screening the title, abstract, and full test. And about the risk of bias 2, ROB2, Robbins 1, Neuroscale Ottawa scale, data synthesis. About the Article 2, is an observational study designed in data source. This study analytical and observational study with a retrospective cohort design that serves hospital information system of the Unified Health System provided by data source and scope inpatient care funded by SUS within the 16 Health Regional Paraná during 2025. Data administrative records derived from hospital admission and the study population, adult patients discharged from SUS affiliated hospital and primary outcomes, unplanned hospital readmission with 30 days of index discharge, the independent variables, sociodemographic, age, gender, municipality of residence, clinical profiles, profile diagnosis, secondary diagnosis, uh, grouped by International Classification of Diseases, ICD-10 chapters, and the care metrics of hospital stay, clinical specialty, admission type, its discharge status. And about the required linkage, the unique patient identification by using birth date, gender, race, and municipality to identify readmission episodes. Validation and cleaning, manual inspection of divergent ICD codes, exclusion of inter-hospital transfer to avoid misclassification. Statistical modeling using a SPSS calculation over overall 30-day readmission rate, bivariate association tests, multi-level logistic regression predictors. About the article 3, in particular, I love this article because it's so different and it's a co-design study. Readmit is a name to this project. It's name a theoretical framework. Intervention name called Readmit, co-design for reduction of hospital readmission intervention. Operational process intervention mapping methodology structured to get iterative co-design stages. Guiding framework, Medical Research Council, framework for development and evaluating complex intervention, and participatory population, readmit adult patients, healthcare professionals, nurses, doctors, social workers, and manager from hospital and primary care, UBS in Brazil, in specifically in city of Maringá. Intervention map have many steps, and the first step is a problem logic model. Então, grounded in the PRECEDE framework with a multidisciplinary planning committee, synthesis global evidence. I will use the article 1 and the location epidemiological predictors, the article 2, to pinpoint high risk cohorts. Step 2. Change logical model. Defines expected behavioral outcomes, patient medication, and environmental outcomes, hospital, and to counter referral to UBS. Constitutes metrics crossing performance objectives with psychological determinants, knowledge, self-efficacy, and risk perception. The step 3, program design, defines central themes, components, and activity sequence, education materials, post-discharge phone calls, care transition protocols, selects theory-driven behavior change techniques. The step 4, program production, drafts, operational manuals, flowcharts, training tools, and patients materials. Conducts pre-testing with target users and clinical staff to evaluate, clarify relevance, and acceptability. Step 5, implementation plan. It's very important step because it identifies program independence, multidisciplinary care teams, and the adopters, health managers, establish training workshops, institutional protocols, and routine supervision feedback. And the step 6, evaluation plan, formulates process questions, and track case metrics, 30-day readmission rates, post-discharge marker attendance, medication adherence, and patient satisfaction. And the thesis it's complete because the article 1 have a global vision, the article 2 local diagnosis, and the article 3 contextualizes solution and to make an intervention to change the health system for more better. And this is execution time. I am here and I hope to go to Duke University for my sandwich doctorate and a good experience and to we focus on in the article 1, 2 and the manuscript writing too. And the expected conclusion, the scientific advancement and the clinical practice and the cell system impact. It's the more important because it reduces avoidable readmissions, optimize bed turnover, and offers a scalable care transition model for small and middle-sized municipalities. This is my references in the care code. And thank you for your attention. I am very glad to be here, and questions and comments are welcome.
Thank you so much. That was such a nice presentation and really interesting work. Thank you for sharing with all of us today. Yeah, like you said, we can just go ahead and open it up to any questions, comments, feedback. Yeah, I'll go ahead and just open up the floor and see if anyone wants to jump in. Yeah, go ahead, Eduardo.
Okay, thanks. Jenny, great job. Congratulations for picking such an interesting thing. I was wondering if, uh, considering you're working with our public health population and you have patient health information as well, do you think it would be valuable and feasible to understand as well during this 30-day period if this patient, um, if it's readmitted, did you have any other contact with health care, such as primary visits, primary clinic visits, or pre-hospital emergency consultations, whether it's EMS or like primary visits in UPAs or any kind of emergency setting visits, even if they don't readmit. Are you considering working with those as well? Thank you. Congratulations.
Thank you. It's important, but you can repeat because it's so. eh, I I will em português, ok? Tá baixo o som, eu não consegui ouvir direito.
Okay, no problem. Let's see if it's any better. Okay, I'll try to make it more objective too. Are you also, instead of looking specifically at patients who are being admitted, looking at SIH, are you looking at SIA too, like ambulatory data for patients who are seeing any kind of assistant in their primary health care or other emergency data from like SAMU or UPAs during this 30-day period in case they are readmitted, to check if they had any other contact with healthcare.
Yes, in the first moment, we choose only the UBS in the primary care, in the hospital internation, only to both. But for example, the UPA, I not to think this in the when I write in the project, but thanks so much, and I will to search more about this.
Hi, Gianni. Good morning. That was a great presentation. Thank you. I know that I do something very similar in Tanzania right now, and I was wondering if you could talk a little bit more about your AIM 3. Who do you think will co-design your intervention? Will you have patients as well and family members, or do you co-design mostly with healthcare workers and hospital leadership or public health officials?
And and about the group, I I think this is important to listen the family too, because the patient and when living alone, it's a very big problem to about the healthcare and self-care to management. And the first moment we drafted only to patient, but it's a topic it's very important to include the family too. And it's I will search more about this, and this is so important and have many topics in the thesis and when you draft this, and oh my god, I forgot this. It's so important in the unity care too, and the Brazil have UBS. It's a small center of health in the city, and so important too. In Astarga have the UBS, but not to call the patient, oh, you okay? Have you need to anything, or this is so important, and thank you. It's a pleasure to hear you because I inspire in you, and thank you so much for the your point in my thesis.
Yeah, you're welcome. I'm excited for you to come to the university in October. Then we can work together. I think the intervention mapping, the six steps, each step could be its own paper in a way, right? So each step could be a whole study in itself. So I agree. I think it's really challenging to figure out what to focus on so that you can do it in one third paper. But I think in your first and second aim, you already get a lot of the information that you use for the intervention mapping. So maybe step 1 and 2 is not that big of a project in aim 3, and you can focus more on the co-design and the implementation phases. So I like how you have the global impact as a systematic review to have a starting point of saying this is what other people have done, right? So you have something to talk about, and maybe you don't have to reinvent something completely new. Maybe it's more to say, based in this setting, based on what we're seeing in our context, this intervention might work. How do we need to change it? So very good.
Thank you.
Hello, hi, Gianni. Very nice presentation. Thank you for sharing with us. Um, I was so amazed by the work you put together and will put together in your PhD, because it seems so big. Maybe I don't know the right word for that. So congratulations also by uh, taking this up, this, because it's going to be PhD is always a challenge, right? But you're up for a big one. And I was wondering, if you are looking at at aiming at non-communicable diseases, or if it's going to be like whatever leads the person back to the hospital, or if for, especially for the intervention, are you going to have a target disease or population, or it's going to be like open? I don't know if I'm expressing correctly.
Mm, you you asked about the target, the now. Yes, about this. It's a point to discuss with John because it's a it's important too in about the article too. Yes, it's it, and that it's and so important because the chronic disease, elderly, many other problems. It's so important to considering in this article because have many problems when you thinking about the hospital readmission and many points and when you search about this have much to be better to search more because have in Brazil have many things to do in the healthcare and but in this point it's so important and I will discuss with John Saucy and we to made my clarify in the methods. It is I can to help in your question.
I think it makes sense to discuss, and maybe you're going to find things out as you go. But I was personally thinking also about, I was conducting a scope revision on the self-regulation's ability, to search for a measure to self-regulation ability in health, in healthy people, not specific to a disease. But at first, I didn't specify like health subjects or overall. I let it open for patient care as well, because it's the same abilities, right? And there are so many scales and instruments developed to self-management and very specific to a lot of diseases, such as diabetes, cancer, or even like baby diarrhea. There's an instrument specific to that. So I had to go back and limited the search, because it's a very big and broad like area of field of work. So I was wondering if you're also personally interested in one, like one part of this, or not yet. Maybe maybe not yet. Maybe you're going to find out this also.
Oh, yes, it's a point important. We we in the article too, we need to see the real problem in a city, for example, in Maringá. We see, oh, this percent of population to returning because have a chronic disease. This returning because have not good mental health. And the other problem because don't have self-care, good self-care management, and to see the real problem, because the article treat to go to the intervention, to draft the intervention. And when you can see all the problem, you can do the good intervention. Because when I see one disease, for example, the chronic disease, have the other problems too. And we can understand all the problems. It's a big job, big work, but we can all the problems, we can make the real intervention or the draft better intervention.
Yeah,
Thank
Gianni,
you.
I think Marcela and also Eduardo talk about a really important topic of in your intervention, you will probably have to decide who you want to focus on, right? Is it a specific patient group? Is it a patient-centered or a health system-centered intervention? Right? Is it that you try to improve the discharge process to provide better education or help with symptom management? Or is it training of EMS providers or primary care physicians to manage it better so that they do not have to be readmitted? Right. And I think AIM 2 will give you a lot of those answers of where to focus. Right. Because I agree, I think you will not be able to have an intervention that covers every readmission, right? Nor should you, because I think it would be too broad and not specific enough to actually measure it or also target a specific group that has the highest. All right, so I'm curious to see what, with the data you have available for AIM 2, what conclusions you can draw. If you can see if there is information about additional EMS calls, or they go to a primary care clinic first before they go to the hospital, or is it, do a lot of people come back 2 days after they leave the hospital and are right back in, right? Does that mean maybe they were discharged just too soon? They should not have been home yet, right? Are those who come back, did they have multiple visits before in the last year, right? Or does this seem to be more of a pattern of they were hospitalized once for an acute condition and then had complications, came back once, right? Those with cancer or other chronic conditions, you'll see that they have a lot more visits usually throughout the year. So I agree. I think AIM 2 will give you an indication of what you want to focus on in your intervention. And then in the intervention too, you will talk to the stakeholders, and they will tell you what they want to focus on and also what they can address, right? Because if they don't have resources to change the entire healthcare network, then what is it that you can target? Maybe that is then a patient-centered intervention that talks about the symptom management abilities, right? Or it's a healthcare worker intervention. So I think AIM 2 will give you a lot of this information. It just depends on finding out what variables you want to look at, and then thinking which variables do I want to look at because I will be able to address them. Right. Yeah.
Okay,
But yeah,
thank you.
great point.
Thank you, Marcela and Yana. I will discuss more with John, and to delimited the when you can make the article 2 and the intervention in the article 3 with the population about the article 2, and then we discussed about this. Thank you so much.
Great. Well, if there is no other comments or questions, we can go ahead and end a few minutes early. Thanks again for presenting to us today. That was a really great presentation. I'm going to go ahead and send you the recording after we finish up today. And that way you can have it if you want to refer back to any of the discussion or anything as you continue to work on your project. But thanks again. Was nothing else from anyone? No final questions?
Gianni, do you have any questions about your project that you want to ask the group?
Okay, I will send you email.
Okay. Okay.
Thank you again
Sure.
about your considerations, and then I am so happy. And now it's my first presentation, and very so nervous, and but it's very very important to me. And when I hope to when I go to the USA, and it's important to this is. And thank you so much for all the listen and the points and the considerations about my project too.
You did great. Thanks so much.
Awesome. Yeah, you did a great job. Thanks again. And you are welcome to come back and present anytime. And it'll be great to have you at Duke coming up in the fall. So we'll be happy to have you. If no one else has any other comments or questions, we can go ahead and hop off a little bit early. But thanks so much, everyone, for joining, and have a great rest of your afternoon or evening, depending on where you are.